a basic diagnosis. So let's see what she had antemortem and whether we could make a correct diagnosis out of it, out of the investigations what we have. So she's a 28-year-old female. We do not know the marital history or obstetric history because she was managed in another unit. So that history is not provided to me. In 2014, at the age of around 22, 23, 20s, in her 20s, she was diagnosed as immune thrombocytopenic purpura because she had thrombocytopenia. We do not have the entire records available, but she had thrombocytopenia. She was treated with steroids, which is the standard of care, initial treatment of choice for ITP. And then she lost to follow up because it was not troubling her. And in 2019, she had ascites, and when they tapped it, it was suggestive of pus. So the investigations revealed ADA, adenosine deaminase levels, which were high and were showing lymphocyte predominant ascites. So the clinical and the surgical team who were treating her diagnosed her to have tuberculosis. So in the meantime, she was also diagnosed to have systemic lupus erythematosus. Now we'll actually, as SLE is so a kind of a disease with varying manifestations. So it is an interesting disease. We can actually discuss about its pathogenesis, immunology, and that is the basis of the pathology and pathogenesis. So it's important we have to discuss the immunology first. So what is special about systemic lupus erythematosus? How is it different from other diseases? So anyone can answer, Dr. Saloni. So what is your view about systemic lupus erythematosus? How is this disease different from other diseases?
Yeah. So basically, sir, this disease is a multi-organ. In this disease, it involves multiple organs. So we cannot like reach to the specific diagnosis whether it is whether the specific organ is involved or not. Like.
So what are all other diseases related to autoimmunity? Can you enumerate some other diseases wherein multiple organ systems are involved?
Yes, again in rheumatoid arthritis, also multiple organs are involved.
Then autoimmunity, rheumatoid arthritis, other diseases like ANCA vasculitis.
Yes.
There are many such diseases wherein you have multiple organ systems which are involved. So what is special about rheumatoid, systemic lupus erythematosus or any other rheumatological diseases? They just do not go away. They just keep on coming and troubling you, the troubles the patient. So this is the natural course of the disease, wherein in the first graph, you can see the accrual of the development of antibodies. The clinical disease starts to set in. So the peaks represents the flares or the disease activity, and they sometimes vanish again coming back. So this goes on and goes on, and the red line indicates the damage which gets accumulated once the flares comes and goes. So in the second graph or the one which is in the bottom of the screen, if you control the number of flares, so you prevent the damage. So this is the basis for this is the basis of this disease, because you have to act early and you have to give lifelong suppression of immunity so that you prevent the damage. So multiple organ systems are involved. So we'll discuss one by one. So any questions in this? So can we proceed to the next slide? So how do you define SLE? What we have just discussed what is the specialty, but how do you define SLE? What kind of disease is it? Why is it occurring? So Dr. Rutika, can you just tell why is it occurring?
Yes, sir. Sir, SLE is basically a type 3 immune reaction, hypersensitivity reaction. So this is involving multiple organs. Majority of the damage happens with the kidney, but other organs that can be involved can be the heart, brain, hematological manifestations, lungs, and this can, if not controlled, this can lead to the death of the patient due to an end-stage kidney failure.
Yeah, thank you. Actually, one other organ you forgot to mention is the brain and blood vessels. You should not discount the blood vessels, because blood vessels is also an important part of any. So it is because of the tissue damage which occurs due to autoantibodies, or it's not necessarily a type 3 reaction. It can be just because of antibodies without immune complex formation also it can happen. So the organs involved most commonly, as you rightly told, it is the kidneys which is the most commonly involved. Heart can be involved, vessels can be involved, CNS, even the peripheral nervous system. Skin manifestations are numerous, lungs, muscles, joints, and why is it occurring? So in worldwide, if you see, Indians are actually prone for developing lupus. South Asians actually are prone for developing SLE. Other than that, North Americans, black population, and Hispanics, people in Mexico and South America, these three Caucasians are not commonly affected. So these three ethnicity group of people actually are prone to develop SLE. And the environment is something like some organisms, microbes. There are many viruses, EBV, ultraviolet radiation, people exposed to ultraviolet radiation, and genetics. It comes in families. We have even seen patients with family history of SLE, mother and daughter getting affected with SLE. So these things can happen. So it can run in families because of genetic associations. So Dr. Humaria, so who are all commonly affected by SLE?
Sir, SLE is a multi-system disorder that affects mainly females, younger females. 90% of the patients are females.
And is there any age predilection?
Sir, younger population.
Yeah, actually, maybe in the Indian scenario, we have younger population, but when you see the data, as I have shown in the graph, the most commonly affected people are the middle-aged women, and to the tune of 8 to 9:1. So males are also affected rarely. We have seen many cases. Even Dr. Arvind has reported many male cases of SLE. So the middle-aged females are the ones who are commonly affected. When there is the disease is mild, it usually responds. When it is severe at presentation, it usually doesn't respond. So first question, I think we have discussed earlier. So anyone can tell what is their experience of diagnosing or seeing a case of SLE either in their clinical duties before joining pathology or even at pathology. Dr. Rhythm Jain, so what's your experience of seeing a patient of SLE or diagnosing an SLE? How did you diagnose? Or anyone who have seen can just unmute yourself and answer. It doesn't necessarily point to Rhythm Jain. Anyone can answer. Anyone who has seen. So if not, we can just what's your experience? If someone friends would have seen.
Butterfly rash will be present.
I didn't get it. We are not able to hear it properly.
So butterfly rash.
Butterfly rash. Okay, yeah, it's a very common manifestation seen in up to 70 to 80% of the people, and it is one of the criteria for diagnosing lupus erythematosus. So we'll go one by one. So this patient got diagnosed after that, after the diagnosis of TB peritoneum as SLE. She had mala rash, oral ulcers. Oral ulcers are recurrent. They come and just come again and trouble the patient. She had photosensitivity, that is exposure to sunlight causes the exacerbation of the rashes. Alopecia, and ANA was 4+. We'll discuss what is ANA. And she also had low C3 and low C4. They are complements which are involved in those are complements that are involved in both the classical and alternative pathways. We'll also discuss about that. And she also had myocarditis. It's cardiac involvement due to SLE. So based on that, she was diagnosed as SLE. She did not have any renal involvement at baseline. So is it clear? Can we move forward? Do you have any doubts until now? So how do you diagnose SLE? So there is a criteria for diagnosing SLE. So with criteria can diagnose 90% of the patients. This is for mostly for trials, so that patients of SLE do not get misdiagnosed. So you can have odd patients who can be ANA negative also. So in that criteria, if you see, so any patient who should be classified as who is going to get classified as SLE should have ANA positivity. If she is ANA positive, then you look at the clinical manifestations. If the clinical manifestations, if you score them, if the score comes more than or equal to 10, then you categorize or classify them as SLE. So can you see which one of the manifestations has got the maximum number of marks? So Dr. Mayank can answer. So you can see.
Dr. Mayank has not joined in actually.
Okay. So Dr. Chiborki Pala.
Yes, sir. The one with classified SLE, sir, which score more than 10.
Yeah, it's class 3 or 4. So that is the importance of pathological diagnosis. So that's an importance of, yeah, that's the importance, that's the importance of pathological diagnosis of lupus nephritis, which has been given in this classification. Even if you diagnose a patient who have class 2 or class 4, so that gives a score of 8. So there are other manifestations, hematologic, wherein you have leukopenia, thrombocytopenia, autoimmune hemolysis. You can have low C3 and C4, which has 3 and 4. The important thing is anti-dsDNA and anti-Smith antibodies. We'll discuss about these antibodies later, but they also have a score of 6. So if you don't have this, even then you can through some other. Those things are not needed. The other graphs, the other flow charts, but with ANA you can definitely diagnose a patient with SLE. So is it clear the criteria how to diagnose an SLE? So if you have a patient with ANA positive and renal biopsy showing class 3 or class 4 lupus nephritis, then the patient is diagnosed as SLE. Even with, if they don't have renal biopsy, you can diagnose with other manifestations, like if they have joint involvement or oral ulcers or low C3, C4. Everything has marks, and then with the marks, if they are more than 10, then you can classify them as lupus nephritis, SLE. So so what are the organ systems which are involved? So already we have discussed, someone just previously told me that the kidneys are the most commonly involved. This graph has just given an information that renal involvement is just present in 20 to 30% at diagnosis. So when you follow the patient serially, they can have renal involvement mostly in, it can be there in up to 60% of the patients. So other than that, what we have already seen, the patients can just present with fever, as we have mentioned in the diagram. Just fever can be there in 31% of the patients. Neurological involvement can be there. Childhood SLE is also there, wherein renal disease is more common. So when you don't treat, this is from a slide from Tiffany Katha, she's also a nephropathologist. So when you have SLE, if you don't treat the SLE, especially lupus nephritis, the flares go on, and ultimately by 30% up to 30% of the people by 5 to 10 years actually develop end-stage kidney disease, and they go on to dialysis. So this patient actually, after 3 or 4 months after the diagnosis of SLE, she presents to the rheumatology team with a SLE flare. This time she also had mucocutaneous hematological manifestations, which can be cytopenias, serositis, ascites, and pleural effusion. And nephritis was there. Previously, it was not there because she was not adequately treated, so nephritis became a part of SLE. Myocarditis, which was present previously, was also there. ANA was 4+. We have already seen dsDNA is one of the specific markers of SLE. Low C3, C4. Now she started to have proteinuria. So we'll discuss what is nephrotic syndrome. So this patient had proteinuria. 24-hour urine protein was 3.7 gram of per day. And urine routine microscopy, which is important in diagnosis of any kidney diseases, showed 2+ albumin by dipstick, and the serum creatinine, this was normal. So she was diagnosed as class 3 plus class 4. We already know, even without other diagnosis, just by class 3 or class 4 lupus nephritis, class 3 plus 5. So when you have class 3 lupus nephritis, you can classify this patient as SLE. So this is a model diagram of a glomerulus encaps, glomerulus with the podocytes. Here you're able to see the pointer, it's okay. So this is the epithelium. This is the capillaries surrounded by the glomerular basement membrane. So here it is there is mesangium, and the mesangium, whatever is there just beneath the podocyte is the subepithelial space, and whatever is beneath the endothelium is subendothelial area. So the subendothelial area and mesangium are so close and connected. There is no intervening glomerular basement membrane between subendothelium and mesangium. So this is the basis of this is the endothelial cell, this is the mesangial cell, and this is the podocyte. So so this patient, this is the SLE is actually defined by deposits, immune complex deposits, which can be there, as I've already told. This can be there in the mesangium, in the subendothelial space, or just beneath the podocytes, that is the subepithelial space. So until now, this part is clear now. So because by classification of lupus nephritis requires this knowledge to further progress. So you can diagnose. Dr. Arvind will actually tell exactly and practically in the slides on how to diagnose a lupus nephritis. But just I'm telling through these diagrams the basis of lupus nephritis. So here there is mild mesangium, as we have already told. The podocytes in the endothelial cell. This is the subendothelial space, and this is the mesangium. So mild mesangial involvement classifies as class 1, and mesangial involvement per se, if there is more than class 1, it qualifies as class 2. When there is focal endocapillary proliferation, it classifies as class 3, and if it is diffuse means more than 50% of the glomeruli are involved, it is classified as class 4. Class 5 is the black dots are the deposits. So here you can see the deposits are there in the subepithelial space. Here they are in the mesangium, here they are in the subendothelial space, here they are in the subepithelial space. So you can have mixture of class 3 or 4 plus 5. Class 6 is there, which is the entire glomerulus gets sclerosed. So to ask someone, Nangpam, what all the manifestations with which a kidney disease patient presents with? Someone who presents with a kidney disease, so what can be their history, and how do the clinician or a pathologist diagnose that this patient might have kidney disease?
So patient will present with hematuria, proteinuria.
And elevated creatinine. That can be also one of these three are the common manifestations with which a patient can present with renal manifestation. So, because this is a capillary and this is the endothelium, and the deposits, if they are here, they can cause the leakage of RBCs from the endothelium can be there into the urinary space, and it can lead to there is endocapillary injury. It can lead to hematuria and proteinuria. But if it is epithelial injury, there is the blood vessel is not in contact with the subepithelial space, so there is just proteinuria because of podocytes leaking the proteins. So there is no hematuria usually. So class 5, as we have already seen, subepithelial deposits, they usually do not present with hematuria, they present with proteinuria, wherein class 3 and 4 can have just proteinuria and hematuria. The mesangium is continuation with the subendothelial space, so they can have just proteinuria and microscopic hematuria, but in amounts which is less compared to class 3 and class 4. So I'll skip these slides. So important thing is asymptomatic hematuria and proteinuria can be there in 1 and 2, because what we have seen is just mesangial deposition. Nephrotic syndrome and acute kidney injury. Acute kidney injury signifies the creatinine has gone up. The creatinine has gone up means that the involvement is very severe. So severe involvement is there in class 3 and 4 because extensive glomeruli is involved, plus subendothelial and subendothelial mesangial, sometimes subepithelial space can be there. So that actually causes more and more inflammation. So you can have acute kidney injury along with nephrotic and nephritic syndrome. So class 6 is basically a patient who has progressed to chronic kidney disease stage. There is no reversibility because the class 6 signifies it is a sclerosed glomeruli. So anyone has questions with regards to how a clinical pathological diagnosis can be made just from the clinical or investigations? If you have questions, just please free to ask. So, if none, then I'll ask a random question to Dr. Rutika. So, proteinuria can be just there in what kind of lupus nephritis? Proteinuria in the sense nephrotic syndrome. Dr. Rutika. So, as I've already told, class 5 is the subepithelial space. So, just nephrotic syndrome is common with class 5 lupus nephritis. So, if you want me to again tell about these things, I can tell, or else I can just proceed. Maybe Dr. Arvind sir will again reiterate these points through pathology. So if you see a patient, if you get a biopsy, if you get a specimen for kidney biopsy specimen or specimen with a diagnosis of nephrotic syndrome in 20 or 30-year-old boys or a male or a female. So what are the clinical diagnosis or what are the pathological diagnosis which are common in this kind of patients? Dr. Humaria?
Yes, sir.
Yeah, please. What will be your differentials when there is
The causes
a
can
20
be
or a 30-year-old presents with nephrotic syndrome?
So the causes can be glomerular or systemic reasons. In glomerular, we can have minimal change disease, membranoproliferative disease, focal segmental sclerosis, IgA nephropathy, and in systemic, the causes can be amyloidosis, diabetes, SLE.
Yeah, thank you, ma'am. I think did you mention membranous glomerular?
In the
Yeah, membranous glomerulonephritis and MPGN are also some of the causes of nephrotic syndrome. So nephrotic syndrome has proteinuria and low albumin with edema. Okay. So I'll just skip through the slides as you have already rightly and correctly mentioned most of the causes. So, but children usually we do not biopsy because most of these have minimal change disease or FSCS. More than 12 years only we do biopsies in a typical case of nephrotic syndrome. So you already mentioned primary membranous nephropathy is one diagnosis which you make diagnose if the kidney biopsy stains for PLA2R, that is phospholipase A2 receptor antigen. There can be numerous other causes of class 5. Membranous nephropathy is class 5 wherein you have subepithelial deposits, and secondary membranous nephropathy may be due to other causes, and SLE is one among them. So I've mentioned here the common causes of secondary membranous nephropathy. So coming to the disease proper, there is genes and environments, there is formation of antibodies, there is incomplete SLE, and you have diagnosis of SLE. So SLE is usually diagnosed late. So what are the renal manifestations? This is maybe slightly tougher question, but if someone can answer, it's well and good. Renal manifestations of SLE, other than glomerular involvement, what other parts of the kidneys can be involved by SLE?
So the vascular component, there can be vasculopathy, which is due to the immune deposition on the vessel wall.
Yeah, then?
So the tubular atrophy can be noted in
Yeah.
these cases, and yes, sir. Otherwise, glomerular.
Yeah, the tubules can be there, as you correctly mentioned. Glomerular part we have mentioned, already discussed. Tubular interstitial component can be there. Vascular changes can be there, and just the podocytes can be there. And very, very rarely, because most patients with the clinical diagnosis of SLE will have lupus nephritis, but very rarely they can have other diagnoses. You should not just consider lupus in your diagnosis just because someone has given you ANA for ANA positivity. So you should keep your diagnosis wide open. And if you have classical findings, then you can corroborate with ANA. Just going by ANA is not advised, and we'll see the reason why also. So initially it starts with glomerular injury, then it involves the tubular interstitium, and subsequently, if you do not treat the patient, it progresses to end-stage renal disease. So it's slide here. Initial involvement is usually glomerular injury. Rarely it presents with tubular, but initially it starts with glomerular injury, progresses to tubular damage. Is it clear for everyone? So just pathology part and clinical manifestations part we have covered. Just because this disease is an autoimmune disease, we should discuss about anti-nuclear antibody. So what is ANA? Dr. Mayank, is he here, Dr. Mayank? So if he's not here, then Dr. Soloni can answer. What is anti-nuclear antibody?
So, sir, anti-nuclear antibody, where the against the nuclear antigens, the immune complexes are formed, and there are 4 types, like against the DNA or histone or ribosomes. So the immune complexes are formed against the these parts of the anti-nuclear antibodies.
Yeah, it's the anti-nuclear antibodies are against the components of nucleus and nucleus, which can be to DNA and its associates, or RNA and its associates. So the hallmark of SLE is the production of anti-nuclear antibodies. It is the pathogenic. It is pathogenic. It is pathogenic in the sense that this is involved in the actual disease manifestation. So we saw the criteria and the how to diagnose a lupus nephritis. So through immunofluorescence, if you have a titer more than 1:80, it is considered significant. If the titer is more than 1:80, below that, the classification criteria doesn't hold good. So what do you mean by ANA? Why do people form anti-nuclear antibodies? It is because it's what we have already seen. There is the disturbance in the mechanism which prevent reactivity to self-antigens. So usually it should not happen, but there is self-reactivity. That's why the ANA gets formed, and subsequently the organ damage happens. So there are various patterns of ANA, but they are not specific. There can be homogeneous, spectral, pattern, peripheral, and nucleolar. So it can be because of SLE and other diseases. Important point is, as I've already told you, just going by ANA positivity, if someone has given a request that ANA is positive, you should not make a diagnosis of SLE unless you see the pathology suggestive of lupus nephritis, because 33% people can have ANA positivity with other diseases. ANAs can be due to DNAs or RNAs and its complexes. So if it is due to DNA, that is double stranded DNA, it is very specific for SLE. And if it is due to anti-Smith, which is against the antibody type is against anti-ribosomal binding protein antibodies. So these two are very specific. Histones can be seen in patients who have drug-induced SLE. So I'm just the last antibody, anti-Rho and anti-La antibody. So can someone tell where have you heard about that antibody? Many of you would have read for MCQs. So what is the importance of those antibodies? It is I can give a clue that it's related to. Yeah, one other thing is congenital heart block. Whenever a patient with an anti-Rho or an anti-La antibody gives birth to a pregnancy, the baby can have congenital heart block. So that is also a clue. So I'll skip these slides. So the deposition of circulating immune complexes, those antigens along with those antibodies can get directly deposited, activate or the antibody directly deposits at a site where the antigen is present, and there occurs an immune complex formation, or a DNA directly goes and attacks the site of injury, wherein and subsequently complement activation happens. So these 3 are the mechanisms through which organ damage in SLE occur. So this is very important. I think most of you would have got it. If there is any question, then please raise your hand, or you can unmute yourself and ask. So this patient in 2019 was treated with cyclophosphamide and steroids, because cyclophosphamide is considered one of the higher immunosuppressives for treatment of lupus nephritis. And subsequently, she lost to follow-up. I have already told you this is a disease which you have to keep it in remission throughout. So, but she didn't follow up. Subsequently, she came with anasarca, it's like bloated up and decrease in urine output. There was menstrual bleed. So if we see the, do you have, can I have just 5 or 10 minutes? No issues. Yeah. So we'll just go through the investigations. So this patient has thrombocytopenia. So whenever you have anemia and thrombocytopenia, so what all will come to your mind? It's just a hematology question. So if you have both anemia and thrombocytopenia, what all will you think of, Dr. Nangam? So it can be anything, but there can be autoimmune, there can be consumptive coagulopathy, or there is formation of microthrombi, which can lead to consumption of platelets, and there can be anemia also. That is one thing which you should keep in mind, because you can see some thrombi in the blood vessels in whatever pathological specimen, be it brain or kidneys, when you are examining. So rightly we saw that there was no evidence of hemolysis, and she has anemia. There is high ferritin and there is low transferrin saturation. So what is this kind of anemia? Can someone answer? There is high ferritin and there is low transferrin saturation. I'll explain them in subsequent slides. Yeah, it's anemia of chronic inflammation. So the next thing is the creatinine was 0.9 previously. It rose up to 3.6. And albumin, as I already told, it is low, and there was proteinuria. And she had pro-BNP elevated. Pro-BNP is brain natriuretic peptide, which is raised in cases of cardiac involvement. So she had tachycardia, she had low ejection fraction. So this all signify that she had cardiac involvement. So what is the importance of APTT? Dr. Rhythm Jain, is he here? Dr. Rhythm Jain?
Yes, sir. So APTT, PT and APTT would signify the clotting factors and the coagulation process, and increased D-dimer levels would signify the DIC process and the fibrinolysis process.
Yeah, what is the importance of APTT in a patient with SLE? So we'll discuss this later. I'll let you know what they are. She had all the cultures done, and an X-ray was also done. So she did not have any evidence of infection because she had leukocytosis. So as we have already seen, the patients can have complement deposition. So there can be the complements may be low, dsDNA, which is a measure of disease activity. So all these three signifies that she had active systemic lupus erythematosus. The antibodies, which the anti-nuclear antibodies, which can be against blood group antigens also, they can have antibody positive hemolytic anemia. So it was not there in the case. So what is APLA? So we'll discuss about that, but this is the reason behind the elimination of APTT in a patient with lupus SLE. So most of you would have heard lupus anticoagulant. The name itself signifies it is an anticoagulant because it prolongs APTT. So we have seen this, that the difference between an iron deficiency anemia and anemia of chronic inflammation. The important point is the ferritin. If it is low, it's iron deficiency. It can have. If it is high, it is anemia of inflammation. But you can have mixed picture also. So these are all the hematological. I have 3 or 4 slides more, so I'll finish it first. So this patient had anemia, which can be multifactorial. They can have autoantibodies positive. Antibodies can be negative. APLA can lead to microthrombi, as I've already mentioned. This can cause consumption of platelets and can lead to anemia and also thrombotic thrombocytopenic purpura and hypoplastic anemias. She can have all kinds of cytopenias and cytosis. Mostly it's thrombocytopenia, but she can have any patient can have thrombocytosis also. So complements, why they are low, we have already seen, I think. So I'll not be the mechanism, just a mechanism, because the antigens and antibodies can cause activation of classical complement pathway. So that is the most important, commonly activated pathway in lupus nephritis, but you can also have alternate pathway activation also. So this patient, after a year, she did not follow. Now she presents with shortness of breath and decreased urine output and hypertension. So she had COVID, which was positive. The X-ray, which was normal previously, had developed bilateral fluffy opacities. So she got intubated this time, treated with multiple antibiotics, but her blood pressure from 190 came down to, she became hypotensive. She developed profuse bleeding from the endotracheal tube, and she succumbed to illness after 10 days of admission. So the diagnosis from these are all cardiac and pulmonary manifestations. So because I just kept this slide because she had profuse bleeding from the endotracheal tube. In any immunological or rheumatological diseases, you have to consider this name, that there can be diffuse alveolar hemorrhage. So she also had myocarditis. So one other important thing is anti-phospholipid antibody syndrome. It is due to antibodies to anti-phospholipid. There are 3 varieties. I think you can go and see, because the pathology part will get delayed. So these are all the manifestations of Aplas syndrome. Most common thing is pregnancy comorbidities. They can have pregnancy losses and thrombosis in the veins and arteries. So she could have had COVID-related changes also, which we are not sure. Only the pathological can tell, because she had the patient had ARDS manifestation. So my final diagnosis is he this time presented with acute respiratory distress syndrome due to COVID, because of immunosuppression, the infection could have come in, and she had hematological involvement because she had anemia, she had thrombocytopenia, and myocarditis was there because there was low ejection fraction and other things which we have seen. So the important thing here is lupus nephritis, which can be proliferative. Proliferative here means class 3 or class 4, because those are all the classes which can be associated with acute kidney injury. Acute kidney injury means here elevated creatinine. So the creatinine, which was normal, got elevated to 3.6. So we really do not know whether there is an evidence of tuberculosis. So I'll happy to answer if there are any questions with regards to this clinical part, and if you have any comments to make, please actually go ahead. And after finishing this, I will hand over the discussion to Dr. Arvind sir.
There is 2 questions. Shall I take it?
Yeah, please. Yes, please go ahead.
Okay. It's the first one says, sometimes we get hypocellular bone marrow. How common is this, and do they revert back to normal cellularity?
So hypocellular bone marrow is common with lupus nephritis because there are many articles and books describing just the hematological manifestation of SLE, and anemia is one among them. So if the patient has some infection, we usually give granulocyte or colony stimulating factors usually to improve the functions of improve the total leukocyte count. Sometimes with erythropoietins we increase the anemia part, but mostly if there is active infection, it's unlikely to respond. Once the infection gets treated with the immunosuppressant drugs, they revert back to normal. In rare cases, maybe they do not respond, but most cases they do respond.
Okay, thank you. Then next question is, can we have overlap of clinical features in, I think, different classes of lupus?
Yeah, as I've already mentioned, class 3 can coexist with class 4. Class 3 can coexist with class 5, and class 4 can coexist with class 5. There can be other involvement together with 3 or 4. They are very rare entities, but if I have to mention that there can be podocytes, just involvement of podocytes or tubular interstitium in addition to the glomerular components. So there can be mixture. It's not very unusual, but it's unusual.
I think there are only 2 questions. Thank you, sir, for this informative session, for explaining the clinical side of the cases.
Thank you,
So
ma'am. Yeah, I'll hand over it to Dr. Arvind, sir, please.
So good evening all. So the clinical point is very well explained by Dr. Arun. So I also learned many points today from the Dr. Arun. So with this, we move to the autopsy findings. I also stopped in between. I will ask questions. So we'll see. So yeah, this is a complete autopsy performed in this 28-year-old female with the clinical diagnosis of systemic lupus erythematosus with renal involvement, and also has COVID-19 infections with diffuse alveolar hemorrhage. And the complete autopsy was performed by bitemporal midline thoracoabdominal incision. And in PGI, we follow the technique is Letule technique. That is, we remove all the organs together. N was removed. Okay, so that is Letule. Apart from that, there are other techniques like Gons techniques, Wichos techniques are also there. And all these non-medical legal autopsies were performed by our junior residents and senior residents. All credits goes to them. So what they observed, I will start with the serous cavities. Has already Dr. Arun told that it can involve any organs, and obviously it can involve any the pleural or pericardial surface also. So the prosecutors observed both the pleural cavities were within normal limit, so there is no pleural effusions. That only we have to look when we are opening the body. And the pericardial cavity yielded 30 to 50 ml of blood-stained fluid, and the peritoneal cavity yielded 1.5 liter of stock fluid. That is assayed. I will start the discussion with the kidneys. So after removing all the organs, we will dissect organ complex. Okay, so here we can see the right kidney, left kidney, and the part of your abdominal aorta, the descending aorta, and we can see the ureters from both the kidney, and it is draining into the bladder. Okay, so we can see this the capsular surface. You can see the capsular surface. I will go to a little bit high power. The capsular surface shows this type of tiny hemorrhagic spots that we can see on these laser areas. The cut surface shows the distinct corticomedullary junction. So from this to this cortex, and from this to this medulla, and we can see this is the pelvic calyceal system. Okay, pelvic calyceal system. There is no focal lesions observed on so always we have to see from the low power view. So the low power examination gives most of the details, and also it gives the details of how much the kidney is involved. So here we can see at this low power examinations, we can see, I mean, this is PA stain. We can see there are many glomeruli here. So nearly all the gloom are involved by the pathology, what I am going to discuss. Yeah. So before going to the pathology, I mean, I took another autopsy to show the normal histology of glomerulus. So here we can see the nice glomerulus. So this is the Bowman's capsule, Bowman's space, also called urinary space, and we can see the capillary loop with capillary wall. Capillary wall also called glomerular basement membrane. Okay, and we can see this pink matrix is mesangium. Okay. So only the three types of cells are present in the glomerulus. Broadly, I can say the one cell that is present in the mesangium with pink matrix. So that is mesangial cells. The one which lines the capillary lumen, that is endothelial cells, and obviously the cells which is circulating on the leukocytes. It could be lymphocytes or monocytes or neutrophils, and the cells outside the capillary wall is called podocytes. So what we have to look when we have the renal biopsy, we have to look whether there is any proliferative lesion is present in any of this compartment. Is there any mesangial proliferation? So when to say mesangial proliferation? Vritika?
So when there are more than 4 mesangial cells in the matrix,
Yeah, good. So up to 3 cells per mesangium is normal. Okay, up to 3 cells per mesangium is normal. If it is more than 3, then we can say that is mesangial hypercellularity. Okay, so yeah. So then there is endocapillary hypercellularity. So endocapillary hypercellularity when there is clogging of particular capillary lumen, then we can say endocapillary hypercellularity that can be due to endothelial cells or leukocytes. So here we can see one nice interlobular artery, tubular epithelial cells, and distal tubules. So with this, I will go to the histology of the current case. So we will explain. Dr. Ritu, yeah. Rhythm, sorry.
Yeah. This is the high power view of the kidney showing 2 glomerulus. The glomerulus shows the sclerosis and a crescent formation with a mesangial hypercellularity. We can also see tubules with a mild atrophy of the tubules and interstitial proliferation.
Okay. So you are telling the crescents. Why? I mean, what is the definition of crescents?
So when we see more than 10% of involvement of glomerulus by the mesangial cells, extracapillary proliferation, we say it as crescent.
Yeah. So here we can see. I mean, in the last slide we had seen nice normal glomerulus, but here we can see that glomerulus is the glomerular capillary wall, and here is the Bowman's capsule and Bowman's space. Okay. Here also we can see this is the Bowman's capsule, Bowman's space, and capillary loop. So here capillary loop is completely collapsed. But you can see here, I mean, the Bowman's space, there is definitely more than 2 layers of cells, that more than 2 layers of extracapillary cells, mostly the parietal cells and mixed cells will be there. And here, I mean, yeah, for the definition, you can say it is more than 10% of the circumference and more than 2 layers of extracapillary to qualify for the crescents. In this case, whatever cells it is circumferential, it is completely engulfing, completely encircling the glomerular capillary tuft. And it is more than 2 layers, so that qualifies for crescent. And how we can classify the crescents further? Can we classify the crescents further?
Yes, sir.
Yeah.
We can classify them as cellular, fibrotic, and fibrous.
Okay,
In
good.
cellular, if the cells are more than 75% and 25% fibrous element, and cellular fibrous 25 to 75, and fibrous more than 75% is fibrous element.
Yeah, okay, good. Huh? Cellular crescents, fibrocellular crescents, and fibrous crescent. Okay. The 75% criteria in some conditions and 90% in some conditions. Okay, so in this case, I will show you in the subsequent slides also. So here we can see both the cells also, and that is the pink, the fibrous component. So this qualifies for the fibrocellular crescent. And here also we can see the pink matrix, so the fibrous component, and that is cell, so that is fibrocellular crescent. And what happened here? You can see the Bowman's capsule here. What happens here? Here and here. So definitely there is a rupture of Bowman's capsule. So this is called rupture of Bowman's capsule. Yeah, this is just further high power. We can see nice one glomerulus. If you trace the Bowman's capsule, not able to trace. So there is a rupture of Bowman's capsule. Is there? Some echo is coming in. And if you see the crescent component, there is both cells and fibrous. Okay, and so this is qualified for the fibrocellular. So how we can classify the crescentic glomerulonephritis broadly? Kritika or Chiborki बोले ना please. Chiborki is here.
Yes, sir.
Yeah, how we can classify presenting glomerulonephritis? So if you are seeing presents in more than 50% of the glomeruli, then we can say presenting glomerulonephritis. So how we can classify further? Broadly, I can say. What are the causes for presenting glomerulonephritis? In other words, okay. If you don't know, okay, no issue. Okay, yeah. So broadly, I can say we can classify the presenting glomerulonephritis based on etiology, okay, why and also morphology. And if you see Robbins also in rapidly progressive glomerulonephritis, so they put in three broad categories. Whether this crescent is due to anti-GBM disease, or crescent is due to immune complex mediated, or it is just post-immune mediated crescentic glomerulonephritis. So that is mediated by ANCA, P ANCA, or C, proteinase 3 or myeloperoxidase. So this is the broad classification of crescentic glomerulonephritis based on etiology and also based on the immune deposits on. How to approach, and how to further approach, how to further categorize this crescentic glomerulonephritis. So what are the parameters will help? So we have to look the nature of the crescents, whether it is cellular, fibrous, or fibrocellular, and the age of the crescents. Whether the age of the crescent is same in all the glomeruli or different in all the glomeruli. So that we have to. And the underlying tough we have to use direct immunofluorescence finding. So these three things are important while approaching the crescentic glomerulonephritis. So I will go through my slides with these three parameters. So if you see this case, we can see yeah. So this what stain this is?
Mesenteric.
Mason trichome stain usually highlights the fibrosis. Nicely highlights the fibrosis. We can pick very early fibrosis also. So here we can see this one glow that is predominantly cells. Okay, there is no fibrosis here. So this glow is qualifying for cellular crescent. Okay, cellular crescent. And if you see this glow, and at the left lower, we can see both cell and fibrous component. Okay, so that is nearly equal amount. So we can put another category of fibrous cellular crescent. If you see this glow, it has more than 90% is fibrous. 90% fibrous, so that is fibrous crescent. So we can see the crescents of variable age in the section. Like we say sections rather than biopsy. This is autopsy case. The crescents of variable age in the renal biopsy sections. So that tells that this could be either immune complex mediated or post-immune glomerulonephritis. The presence of variable age tells that the insight of injury happened at multiple different times. Okay, multiple different times. If you are seeing the presence of same age, suppose if I'm seeing 10 gloom, all the 10 glomeruli are showing cellular crescent, then most likely diagnosis I can say is anti-GBM disease. Okay, anti-GBM. So in case of anti-GBM disease, you will find the crescents of same age. If you see all the 10 gloom will show cellular crescent. Okay, so obviously the next diagnosis will come from the direct immunofluorescence. In post-immune glomerulonephritis also, you will find the crescents of variable age. Okay, next thing we have to look at underlying tuft. What underlying tuft is showing? Okay, so what this underlying tuft is showing? Gangam. Yeah, so, sorry, I mean, if I pronounce wrong. Yeah, gangam. You are here? Yeah.
Yes, sir. Sir, mesangial matrix is proliferated, sir.
Okay, mesangial matrix is proliferation. Okay. Okay. So can you show which is mesangium, which one is mesangium, which one is endocapillary? Can you do that from your laptop or?
Yes, sir.
Yeah. Okay. No issue. No issue. Leave it. Okay, no issue. Okay, I will show from here only. But the basic thing is you should know. Okay, so here you can see that this is the endolumen. Okay, here I can see 4 cells clogging the lumen. So this is endocapillary hypercellularity. Okay, endocapillary hypercellularity. But here I can see there are 4 or 5 cells with the background pink matter. So this is mesangial hypercellularity. Okay. There is both endocapillary and there is also mesangial hypercellularity present. Right. So what this globe is showing, we will say next is Saloni. Yeah, Saloni, you can come. You can tell what this globe is showing. What this spot of globe is showing.
Sir, here the mesangial proliferation is seen and hypercellularity is seen, as well as the wire looping of the capillary wall is seen.
Good. Okay. I mean,
And
so
the
this,
above glomerulus, it is showing the crescent formation, cellular crescent formation.
okay. Good. And this slide is showing all the components of proliferative lesion. Here you can see nice fibrocellular crescent with a rupture of dominance capsule, and your underlying tuft, you can see that the mesangium is expanded, and there is mesangial hypercellularity, 4 cells here, and here you can see endocap hypercellularity, so all here. And what this globe is showing, you can see, I mean, little bit, this is more eosinophilic, no more pink material, like I can say hyper eosinophilic material, so that is present along the glomer capillary wall. That is so-called wire loop lesion. So-called wire loop lesion. So why the wire loop lesion is occurring? Yeah, why there is wire loop lesion? What is the reason for wire loop lesion?
Subendothelial deposition of the immune complex.
Good, very good, very good. As Dr. Arun pointed out, the deposits can be in mesangium, it can be in subendothelial, it can be in subepithelial or mesangium. Okay, if the deposits is massive in subendothelial location, if massive in subendothelial location, then you will find this wire loop. And if the deposit is more than massive, I mean, I can say very huge deposit, if it is present in the subendothelial lesions, you can see these things also. What this globe is showing now?
Yes, sir, here mesangial proliferation and wire looping is seen again in this section.
Wire loop lesion. My the pointer is pointing towards what?
Mesangium.
This one. Can you see this thing, that round structures?
Yes.
Yeah, this is so-called hyaline thrombi. Okay, hyaline thrombi. Hyaline thrombi or hyaline deposits, I can say. Hyaline thrombi is again misnomer. Okay, it is not actually thrombi. And this is also due to massive subendothelial deposits. So because of sectioning, I mean, it looks like that it is present within the capillary area. So this hyaline thrombi is also due to subendothelial deposits. Here you can see that wire loop again. Okay, wire loop again. Nice on the PA stain. Okay. Yeah, so the underlying tuft we have to look. Okay, so in this case, the underlying tuft is showing the all proliferative changes like endocap. We are seeing mesangial proliferation. We are seeing, and the wire loop are seeing. So all these are classical features we can see in immune complex mediated glomerulonephritis and particularly lupus nephritis. See, but if I'm not finding any proliferative lesion in the underlying tuft, and again this could be either anti-GBM disease or positive immune. In case of immune complex mediated glomerulonephritis, immune complex mediated crescentic glomerulonephritis, you will find proliferative lesion in the underlying tuft. That is the point. So in addition, so in some of the glomeruli, we can see these changes in this case. So what this it shows? What it shows, Umaria? What is glomi showing?
So there is mesangial proliferation, so thickening of basement membrane.
You should start with that. Okay, I mean, you can see the global thickening of your capillary wall. That is global. So this is different from this thickening. This is like crescent moon shape thickening. No, this is because of subendothelial deposits. But in this globe, what it is showing, that is global thickening of capillary wall with stiffened loop. It's the capillary loops a little bit stiffened. Okay, it's like stiffened. So this type of stiffening will be seen in which glomerulonephritis. Stiffening of capillary wall with lifted up podocytes. You can see this is the podocytes. Okay, podocytes are now it is lifted up. So that is seen in the membranous glomerulonephritis. So the point is here, there is additional component of membranous glomerulonephritis, that is class 5. Okay, as Dr. Arun told that the class 4 can be accompanied by class 5 lupus nephritis. In this case, we can also see that in the. So obviously, we should look the blood vessels. So next to the glomeruli, here we can see one interlobular artery. So that is not showing any evidence of vasculitis. Okay, so there is no vasculitis on light microscope. So what is the next thing? So we had find that this type of proliferative lesion. The next thing we should go for immunofluorescence. What immunofluorescence?
Direct immunofluorescence.
Good, direct immunofluorescence. What is the difference between direct immunofluorescence and indirect immunofluorescence? Chiborki, you know what is the difference between direct and indirect?
No, sir.
Okay, so direct immunofluorescence will be done on tissue. Okay, directly we'll put antibody on the tissue. So indirect immunofluorescence will be done on mostly on serum. Okay, direct immunofluorescence will be done on serum. So this is direct immunofluorescence. The example for direct immunofluorescence. Yeah, so Dr. Arun,
yeah, what we discussed earlier, ANA, finding an ANA is through indirect immunofluorescence, and this is direct immunofluorescence, where what you see in the biopsy.
Okay. So here, I mean, so on direct immunofluorescence, we are performing on renal tissue. Okay.
So usually we use Mitchell's medium or normal saline can be used for the direct immunofluorescence testing. So normally we have to use 7 antibody: IgG, IgA, IgM, C3, kappa, lambda, and C1Q. So here we can see the nice deposits for IgG and kappa and lambda, IgA, IgM in the mesangium, okay, in the mesangium and also along the globular capillary wall, okay. This is just high power of IgG. Here we can see the immune complex is fixed labeled, okay, fluorescein isothiocyanate labeled antibody. So easily we are seeing as green color, okay, green color. So that is giving the green color. Here we can see the deposits of IgG on the mesangium and also along the capillary wall, okay. So in lupus, the deposits can be in mesangium, can be in subepithelial, or can be in subepithelial. Yeah. Okay. So what is the criteria for class 5 lupus nephritis? Anyone? When to say class 5 lupus nephritis?
There will be glomerulosclerosis.
Yeah.
Advanced glomerulosclerosis.
That is class 6. Okay, that is class 6. If I am finding 90% of the glomerulosclerosis, that is class 6. Okay, the class 5 is also called membranous nephropathy. It's a membranous glomerulonephritis. So when to say that class 5, if you're finding the deposits along the capillary wall, so here you can see the greenness, the immune complex deposits along the capillary wall. If it is present in more than 50% of the tuft, so if you see the total is 100%, if I'm finding the deposits along the capillary wall involving more than 50%, I can say that additional class 5 component is present in this. Okay, so we should add the additional class 5 category in our report. Okay, so this patient also has class 5 lupus. And apart from that, we are finding immune complex deposits in the artery also, but I'm not finding any vasculitis or like. Okay, so this also one should know. So this is a immune complex deposits full dose pattern and proliferative changes in nearly all the glomeruli. Okay, in nearly all the glomeruli, that is more than 50% of the glomeruli, and with proper clinical settings and laboratory features as explained by Dr. Arun. So this is very well fit with the lupus nephritis. So there is no doubt. Okay. So now the next things with what class? What class? Okay. So there are 6 classes of lupus nephritis as per ISN or PS. So this case as showing proliferative lesion in more than 50% of the glomeruli. That means diffuse. So class 4. Okay, class. And we are finding the deposits along the capillary wall also. So that adds the class 5. So that is class 4 plus class 5 lupus nephritis. Any doubt till now? Is it fine? Okay. Next things we have to look for activity and chronicity score. Okay, the activity and chronicity score. So this is very important for the clinicians to decide upon the treatment. So what treatments we have to give, whether the treatment has to be given or not. Okay, if suppose if you are saying already that is 90% IFTA, then there is no need to give immunosuppression. Okay, so we should document the activity and chronicity score in all cases of lupus nephritis if it is okay. Anyone know what are the parameters we have to look for activity and chronicity? So this question goes to Gam. Yeah. What are the parameters we have to look for activity? Okay, anyone?
So, modified activity score shows endocapillary hypocellular, neutrophils are fibrinoid necrosis, wire loop lesions, and cellular fibrocellular crescents. Okay, good. These 5 parameters we have to take for activity as per modified NIH activity in the score. You rightly pointed endocapillary hypercellularity, neutrophils or carrier exist, fibrinoid necrosis, hyaline deposits or wire loop lesion, cellular crescents, and interstitial. Based upon the involvement, so that is score, whether it is less than 25%, 25 to 50%, or more than 50%. And for the fibrinoid necrosis and the crescents, we should multiply the score by 2. And the total activity score is 24. Okay, the maximum activity score is 24. Similarly, the 4 parameters we have to look for the chronicity index: total glomerular sclerosis, fibrous crescent, and atrophy, and fibrosis. And the total score is 12. So this is also very important for the clinicians whether the patient has to be treated or anything. Dr. Arun?
Actually, as a clinician, this is very vital for pathologists gives a diagnosis of lupus nephritis. When we see when the activity score is high, we usually immediately start the patient on immunosuppression. And for chronicity score, we may taper down or decrease the immunosuppression, or we may not give it if the chronicity score is very high. So this is very important.
Yes. Okay, so in this case, we calculated the activity score as we are seeing crescents in more than 50% of the glomeruli. That is 2 by 2 into 3. And the overall activity score is 12 out of 24, and the chronicity index is 4 out of 12. Overall, we can put this case as class 4 plus class 5 lupus nephritis, and we are finding immune complex deposits on the vessels, but there is no vasculitis. So that is called uncomplicated vascular immune deposits. So this is the final renal diagnosis of this case. So this patient also underwent the renal biopsy in the prior admission. Okay, the 3 months, 4 months before the patient is admitted and has underwent biopsy during that time. Here we can see the nice core. Okay, and the first thing is we have to count the number of glomeruli in the biopsy. Okay, we can see that nice glow, and there is no IFTA. There is no IFTA, so the chronicity is not there. And at this hyper also we can see that none of the glomeruli is showing crescent. Okay, so the autopsy is showing the crescent in more than 50% of the glomeruli, but there is no crescent in any of the glomeruli. And focally, then only one gloom as showing the endocap hypercellularity. So 2 gloom has shown the endocapillary hypercellularity. So that tells the score of 2. So in that biopsy, it was put under the class 3. Okay, class 3. Why it is class 3? What do you mean by class 3? Tony, what do you mean by class 3?
Deposits in subendothelial region.
What is the difference between class 3 and class 4?
If it is massive, then it is a class 4. If it is focal, then 3, and if it is diffuse, then it is class 4.
Good. That answer only I expect. So if the involvement is less than 50% of the glomeruli, that is class 3. If involvement is more than 50%, that is diffuse. Okay, then class 4. Yes. In this case, the proliferative changes is present in less than 50% of the glomeruli. The biopsy, so we put under class 3 plus class 5 lupus nephritis. That time activity score was just 2, and there was no chronicity. So if you compare the biopsy from the autopsy findings, so you can see there is definite progression from class 3 to class 4. And also there is definite progression in the activity indices from score 2 to score 12, and also some progression in the chronicity from 0 to 4. Okay. So this progression is happened probably because the patient is not on a follow-up and didn't take the immunosuppression. Okay, so this is the findings. Any doubts in the kidney? So we'll move on to the next organs quickly. Okay. So yeah, any doubts? You can rise. Okay. Okay, so we'll move on to the heart. Okay, so what findings we can expect from the heart in case of lupus? Ritika Shah? Yeah, Ritika, you can tell. What are the
So there
findings?
will be presence of pericarditis. The outer layer of the heart will not be the usual glistening cell or glistening appearance, and it will seem to be thickened due to the inflammation. There can be
Okay, the lupus is the case, yeah, which can involve any serous layer. So the pericarditis can be there. Okay, pericarditis can be there. It could be fibrinous pericarditis. If it is fibrinous pericarditis, it will find the bread and butter appearance. But here you can see the heart. This is the right auricle, and this is your ascending aorta and its branches, and this is the pericardium. So the active lesion, active pericarditis is not present, but you can see this type of white patch, milk patch on the anterior aspect of the pericardium. So this could be healed pericarditis because this patient also received the immunosuppression before. Pericarditis might have present, but it is healed. So we open the heart by usually by inflow-outflow method to look for any pathology. Okay, this is the right atrium. You can see your the muscular actinate vessel, and this is your tricuspid valve and right ventricle, and this is your left inflow tract and left outflow tract. Okay. What we have to look for, look in case of lupus in valves. Valves mean what is the finding in case of lupus?
Non-infectious vegetations.
Vegetations. Good. Okay. What is the name of the vegetation?
Liebman
Liebman
sac.
sacs vegetation. So Liebman sac vegetations can be in lupus, but in this case, I mean, there is no vegetation in the valve. Yeah. And next thing, the coronaries has to be the right coronary, left anterior descending artery, and the left circumflex artery. So this has to be done routinely in all the autopsy cases. So here we can see the sections of all 3 arteries, but that is not showing any thrombus. Okay? There is no thrombus in the and here so this is the section from the heart, pericardium, and this is your myocardium. Okay, myocardium. Can you able to appreciate this myocardial fibers? This is the pericardium, and the pericardium is a little bit thickened. That I shown that white patch, no, that white patch. So that is markedly thickened and sclerotic. And the inflammatory cells are very sparse. So that happened probably because of immunosuppression. Lymphocytes. What this myocardium is showing? Gangam. What is myocardium showing? What are the changes?
Haphazard arrangement of the myocardial muscles.
Okay. Good. So what happened? What are these things? My point. What are these things? The white spaces. No. What are those?
So it's a mature adipocytes are present in between the muscles, myocardial muscles.
Yeah, so there is a lot of edema is there. This is edema. The edema is getting separating the myocardial fibers. इसलिए I mean we can see your fibers are the fibers are arranged haphazardly. A lot of myocardial edema is present. And this is another section we can see the interstitial edema that distorting the myocardial fibers, and we can see the sparse interstitial inflammation in the myocardium. So this is just high power, and some of the fibers are atrophic and degenerating with a lot of interstitial edema with sparse inflammation. And here we can see one. What is this?
Blood vessel.
Yeah. We should
Thick
not say.
wall blood vessel.
Yeah. Always, I mean, the pathologist should say whether it's artery, vein, or capillary. This could be the intramyocardial artery or the intramyocardial artery. Here also we can see the perivascular edema, and there is mild inflammation in the pericardial space. So yeah, next we went with the immunofluorescence. We can see this is the heart again. Okay, again that is we can see the immune complex deposits present both in the intramyocardial artery, intramyocardial arterial wall. Here again we can see some of the myocytes are also highlighted on MG imaging. So that tells that there is immune complex deposits are present in the both intramyocardial and pericardial cells. So that is causing the injury. So this is a findings of lupus myocarditis and lupus pericarditis. So coming to the brain, so the brain, there's grossly there is not much changes in the cerebral cortex or cerebellum, but the midbrain and pons has shown the petechial hemorrhages here. Has shown this is one of the capillaries. You can see there is significant leukostasis here. And what are these structures?
Oligodendrocyte.
Oligodendrocytes. Yeah. Okay. I mean, so these are neurons. Okay, these are neurons. And the point is, no, that little bit large, like star shape. No, this is the cell body of the neuron, and this thing, the small thing that lymphocyte-like cells. No, this is oligodendroglial cells. Okay, this is oligodendroglial. You can see it. So this cell is neuron, and this cell is your oligodendroglial cells. So you know that oligodendroglial cells helps in myelination of central nervous system. Okay. 1 to 2 oligodendroglial cells can be seen in around the neurons. So these neurons are a little bit angry looking. I can say it's more reddish. That is because of ischemia happened due to leukostasis. And the sections taken from the hemorrhagic areas shows the areas of hemorrhage. And here we can see one artery entrapped in the hemorrhagic focus. So that here also we can see the hemorrhage in the pons area. That artery is also showing IgG deposits on directly. So that tells that there is lupus mediated injury in the brain also. The brain is the next organ commonly in systemic lupus. That is lupus vasculopathy with microhemorrhage in the brain. Okay. So the first part of our autopsy findings are over. Related to the lupus is nearly 75% over. I will come to the lungs. Okay, lungs. Can you see this? Okay, lungs. Both the lungs. Someone is echoing. Yeah. So both this can see both the lungs. So what this pleural surface is showing? Kumaria, you want to explain the gross of this lung?
So there's a rough on the right lung surface.
Right lung, left lung. How to differentiate which one is right, which one is left?
So the lung so various segments of the lung. The right lung we have two, and in left we have three.
Okay.
So,
okay, good. Okay. So we can see this is the trachea. Okay. The in trachea, what is deficient in which wall? Anterior or posterior wall? Trachea. Yeah, I noted that. Okay. So, I mean, the posterior surface has no cartilage. Okay, no rings. Okay, that is the posterior aspect, and this is the left bronchus and right bronchus. The left bronchus is more long and lateral. Okay, the triple L. The left is long and lateral, and right bronchus is short and it is. Okay, the right lung and left lung. We are viewing the lung from the posterior aspect. Okay, posterior aspect. What is pleural surface? We can see this mottling. Okay, there is exaggerated mottling. You can see. This means that the patient has a lot of breathing difficulty before expired. So we can see this extended modeling. The cut surface of the both the lungs. Okay, the cut surface of the both the lungs. Okay, it is showing hemorrhage. Okay, now it's completely hemorrhagic, alternating with the pale areas. Okay, and these are not hemorrhagic areas, but of hemorrhagic area that is present in both the lobes of right and left. So in these slices, you can see nice the hemorrhagic areas, discrete hemorrhagic areas, and also some of the hemorrhagics are concealed. If you note down the history, this patient has bleeded profusely in the endotracheal tube before demise. Okay. And yeah, as a part of autopsy, we should examine the pulmonary artery also to look for any thrombus. There is no thrombus in both right and so this patient has both lupus and COVID-19 infection. Okay. What is expected in autopsy? What are the COVID-related changes you can see in the lungs? Chiborki Pala, you know what are the COVID-19 related changes in the lung?
Yes, it leads to fibrosis of the lung.
Fibrosis, okay. Not directly fibrosis. What is the first thing will happen? COVID-19 related changes in the lung. So since we crossed already COVID-19.
So severe capillary congestion will be seen, edema will be seen, microthrombi will be present in the lung, and sometimes there might be alteration of the pneumocytes also.
Good. Okay. So why it is happening? Alteration of pneumocytes and all. What is the basic thing? Is diffuse alveolar damage. Okay. The basic pathological term is the diffuse alveolar damage. AD. The corresponding clinical term is acute lung injury. ARDS, acute respiratory distress syndrome. Okay. Acute respiratory distress syndrome. That I will show you the findings. Okay. What are the lupus related changes we can see in the lungs?
Pleuritis. Again.
Good. Pleuritis, then
Pneumonitis.
pneumonitis. Good. Pleuritis and
Alveolar hemorrhages because of
alveolar hemorrhage
vessel
also.
occlusion.
Okay, good, good. Okay, yeah, so these are the changes which can see.
One more thing I mentioned that we also examine the pulmonary arteries. So there can be pulmonary arterial hypertension, there can be thrombi. So blood vessels are important in examining any part of the organ related to lupus.
Okay, so this is again, I mean, the lower section. So we can see the areas of hemorrhage and the alveolar parenchyma. Okay, so I will just explain this thing and next thing I will ask questions. Okay, so here you can see that. So before going to this, so this is the histology of lung in a relatively normal patient. You can see that these are the alveolar spaces, interalveolar septa with capillaries. I can see it is, I mean, this much thickness only. Okay, and you can see on the pre-acinar artery here. So this is normal. Okay, not relatively normal. And come to this section, what it is showing? Yeah.
Hyalinizing.
किसको पूछो गैंग you answer.
Sir, alveolar septa is replaced by fibrin strand.
Okay.
Dilatation of the
fibrous
strand.
Okay, I didn't get the fibrous strand. Okay. Okay. So if you see that, I mean, if you see the thickness of the interalveolar septa, this much thickness only the normal. But these are alveolar spaces. There is marked widening of interalveolar septa. Okay, you can see one alveolar here, one alveolar here. So the interalveolar septa is markedly widened. Okay, why it is widened? Why it is widened? That we'll see this. Again, this PA stain. You can see this is the one alveolar spaces, and this is another alveolar spaces. There is marked widening of interalveolar septa here. Here also we can compare with this inside diagram. This is the normal thickness of interalveolar septa. There is marked widening of interalveolar septa. So why it is widened? Why it is widened? Here we can see that this is the one alveoli here, and this is the another alveoli. And the interalveolar septa is widened because of again edema and lot of inflammation. Okay, there is mixed inflammation present in the interalveolar septa. And what this alveoli is showing?
Hyaline membrane.
Hyaline membrane.
Ah, good. What do you mean by hyaline membrane? Umaria, what is hyaline membrane?
Deposition of fibrin in the alveolar septa.
Interalveolar septa. So, I mean, what it tells that why it is getting deposited? What is the reason for the deposition?
Because of intense inflammatory infiltrate and
whenever there is the capillary wall injury, so the fibrin is coming from where? From where the fibrin is coming? The blood, no? The blood. So what is the barrier between the alveoli and capillaries? What is the barrier? That is alveolar wall, no? So whenever there is break in the alveolar wall, whenever there is breaking in the alveolar wall, the fibrin is leaked from the capillaries into the alveoli and it forms the hyaline membrane on the septum. This is contractile hypereosinophilic. This is the refractile eosinophilic membrane along the capillary wall, so called that we can see in the acute phase of diffuse alveolar damage. The hyaline membrane that tells that this diffuse alveolar damage is in. The further hyperview, we can see that hyaline membrane, it is completely encircling the alveolar wall, and here a lot of the pneumocytes are also present. Apart from that, we can see the fibrin ball, and the fibrin ball also tells that there is diffuse alveolar damage in acute. So here we can see this type of things. So these are type 2 pneumocytes. So as a result of injury, the type 2 pneumocytes now with nice type 2 pneumocytes line and one capillaries microthrombi as told by Humiara. Okay, again the type 2 pneumocytes are more prominent along the capillary wall, and a lot of these formations happened in the alveolar space. And as a result of viral infection, you will find more giant cells both in the lumen and along the wall. So this is because of only COVID. In COVID cases only, we started seeing this type of thick mucus plugs completely obstructing the bronchioles and bronchus. So yeah, so this is the classical finding of diffuse alveolar damage. So broadly, we can classify the diffuse alveolar damage into exudative phase, organizing phase, and fibrosis. So exudative phase is characterized by hyaline membrane and fibrin thrombi and type 1 pneumocyte necrosis. Proliferative phase is characterized by type 2 pneumocyte hyperplasia and interstitial fibroblastic proliferation and medial hypertrophy of the vessels. So this case is fitting in the category of transition from the exudative phase to proliferative phase, as we have seen both hyaline thrombi and as you should not say fibrosis. Fibrosis is more bluish, so that happened more than 21 days. That is due to dense collagen deposition in the interalveolar septa that leads to remodeling changes in the lungs, both in the parenchyma and the blood vessels. So the acute lung injury is in this case is due to diffuse alveolar damage, exudative phase. Apart from this, we had also seen the hemorrhage, multiple foci of hemorrhage as is shown in the cross. There are discrete hemorrhages and confluent hemorrhages. We will concentrate on these hemorrhages. We'll concentrate on these hemorrhages. So again, you can see this alveolar septa, and alveolar septa is completely filled with the RBCs. So that is diffuse alveolar hemorrhage. So what are the causes for diffuse alveolar hemorrhage? Anyone? Causes, please highlight. Rhythm, yeah, you can highlight.
So pulmonary arterial hypertension could be one of the cause for the diffuse alveolar hemorrhage. Maybe trauma. Trauma, yeah, okay. This and lupus cause diffuse alveolar hemorrhage.
Yes, sir.
So pulmonary arterial hypertension.
Pulmonary hypertension, but lupus can cause diffuse alveolar hemorrhage.
Yes, sir. It can cause.
Yes, it can cause.
So broadly, we can classify the diffuse alveolar hemorrhage from the pathological aspect. Okay, whether this diffuse alveolar hemorrhage is accompanied by capillaritis or not. So based upon there are some etiological clues. Okay, whether this diffuse alveolar hemorrhage is accompanied by capillaritis or not. Okay. Here you can find the list of causes for diffuse alveolar hemorrhage with the capillaritis and without capillaritis. Okay, without capillaritis, we can see the blank hemorrhage. So with the capillaritis, you will find in possible small vessel vasculitis, including vaginous, eosinophilic granulomatosis polyangiitis, and lupus and other connective diseases. The bland hemorrhage usually seen in thrombocytopenia, and as the rhythm told, the hypertension, mitral stenosis, some cytotoxic. There are some causes for hemorrhage without capillaritis. In this case, if you see that, I mean, you can see the alveoli that is showing completely filled with RBCs. Here you can see this is the interalveolar septa, and you can start seeing there are neutrophils here infiltrating the wall rather than in the lumen. So that suggests the additional capillaries. And the arteries examined did not show any evidence of vasculitis. So we have to rule out the vasculitis. If it is possible, small vessel vasculitis, you will find the vasculitic changes in the relatively larger artery also. And further, we performed immunofluorescence on this. So you can see the IgG deposits in the pulmonary capillaries along the wall. So again, that tells that here the injury, the capillarities and diffuse alveolar hemorrhages because of IgG immune complex mediated injury. So again, you can see at this high power, the interalveolar septa, the IgG deposits along the capillary wall, and also there is C4D deposits in the capillary. This diffuse alveolar hemorrhage with IgG and C4D deposits in the capillary, so that qualifies for lupus pneumonitis. And so, I mean, this case has shown also DAD and diffuse alveolar damage. So this DAD, diffuse alveolar damage, can happen both in COVID and lupus itself. Can happen both. There are several causes for diffuse alveolar damage, and COVID and recently, it's a highlighting cause for diffuse alveolar damage. It can cause DAD. So we further investigated this issue for RT-PCR also, and it turned out to be positive for severe acute respiratory distress syndrome. So we so this was done by our virology team. And further, we performed the IHC. There are specific IHCs are available for this source. So that highlights the some of the type 2 pneumocytes and also discombinated. So there's both lupus findings and COVID-related findings are present. Coming to the other organs, first, as we cross the time, we move forth. The liver, here we can see there is no focal lesion. Spleen also no focal lesions. There is central venule, portal tract. So there is no disarray, no fibrosis on reticulin, on mass and strikum. It's normal. And spleen, what we can see is there is marked depletion of lymphoid cells. There is marked depletion of lymphoid cells. You can see more of red pulp. And we performed the IHC also, both the B lymphocytes marker and T lymphocyte marker. And spleen tissue also submitted for the PCR, that also turned out to be positive for salt. The lymph node, here you can see the lymph node. What the lymph node is showing is the marked dilatation of sinus spaces, and most of the sinus space shows increasing number of histiocytes. What these histiocytes are showing? The last question to the Ritika. Yeah, what these histiocytes are showing?
So the histiocytes have actually taken up the red blood cells of the red sinusoids. So
Okay.
sorry,
What
taken
we
up
can
the
say?
red blood cells from the hemorrhage.
What is the name?
Hemophagocytosis.
Hemophagocytosis.
Not only RBCs, this is the one histiocytes, not only RBCs, you can see the lymphocytes also.
Yes,
It's called hemophagolymphohistiocytosis. So that can happen in a viral infection due to cytokine storm. And so both again that B marker and T marker are markedly depleted in the lymph nodes were negative for SARS. The small intestine and large intestine were unremarkable, so I'm not showing that, and thyroid and adrenal and pancreas and skeletal muscle. So this is our final autopsy diagnosis in this case. In known case of lupus with relapse and flare and COVID-19 positivity. So the kidney is showing the lupus nephritis class 4 plus class 5 changes with uncomplicated vascular deposits. With activity score of 12 out of 24 and chronicity 4 out of 12. And there is diffuse alveolar hemorrhage with IgG and C4D deposits that suggest the lupus pneumonitis diagnosis. Lupus myocarditis, pericarditis, lupus vasculopathy in the brain. There is diffuse alveolar damage exudative phase with PCR positive for SARS-CoV-2. This diffuse alveolar damage, again, it can be due to lupus or it can be due to COVID, but here, so that is additional positivity for COVID also came from the patient. The significant lymphohistiocytosis in the lymph node. There is marked lymphoid depletions in the lymph node and spleen. This happened probably because of the immunosuppressions given during their life. This I thank you. Questions on both pathology and clinical. Any questions you want to ask?
Any questions? Chat box also, please someone can let us know.
There was a pending question.
Yeah, yes,
the question was, how do we explain high D-dimer but not PT in one of your cases? In that case with menstrual bleeding.
Actually, the voice is not clear. We are not
I
able
didn't
to
get the questions, ma'am. We didn't get the questions.
The question is, can you hear me now, sir?
Yes, ma'am.
Okay. How do we explain high D-dimer but normal PT in this case never?
D-dimer is not that sensitive or specific, so you can take this sensitivity and specificity to 80%. So there are criteria and scores. D-dimer is one among the criteria. You cannot fully explain. So if someone has just D-dimer, it doesn't mean that there is consumption, or sometimes there may be some an evidence of diffuse intravascular coagulation, even though it is not there in the biopsy autopsies. But chronic inflammation, some malignant diseases can have DAC, but yeah, it is. It's a non-specific finding, as like ferritin. D-dimer is non-specific, but it is one of the criteria to diagnose this pulmonary thromboembolism and other things.
Yeah, the D-dimer can be increased in DAD also. In this case, there is diffuse alveolar damage.
Okay. There's no questions, Dr. Arun. I think it was interesting and people could more or less understand the pathology. As you explained, as you were very clear about.
What's the question? Pathogenesis of lupus.
No, we don't have any questions for Dr.
Any questions? Yeah.
Arun.
Okay, thank you. Okay. And if there is no questions.
Yeah. Thanks a lot, Dr. Arun. Both of you really made the whole discussion really interesting.
Thank you, Nomia.
And thank you for the slides also. Thank you, Dr.
Thank you, Nomia. Thank you, everyone. So thank you, students. Hope you learned nicely. So all autopsy it is not. So this autopsy definitely taught us more. So with this, we are bye to everyone. Bye.
Thank you. Have a good evening.
Good night to all.
Thank you.